Hello, my name is Nathan Wong, and I'm editor-in-chief of the new cardiometabolic disease clinical community, which is available on CardioSource. Today, I'm talking with Dr. Michael Blaha, Assistant Professor of Medicine and Epidemiology at the Johns Hopkins Cicerone Center for the Prevention of Heart Disease and Associate Editor with me for this CardioSource clinical community. Today, we will have a discussion on the topic of treating high cholesterol or treating atherosclerosis risk. Welcome, Dr. Blaha.
Thanks, Nathan. It's my pleasure to join you today, and of course, my pleasure to work with you on this fantastic section of the CardioSource website where I think we're going to cover a lot of the important debates in cardiometabolic disease.
So for years, clinicians have been predominantly making treatment decisions, for example, with statins based on serum levels of cholesterol, particularly LDL cholesterol. However, there's an emerging notion among some experts that strict reliance on cholesterol measurements might be misguided. Can you shed some light on this issue?
Sure. Right. We know that single measurements of cholesterol taken at an adult age, like we see in epidemiologic studies like MESA or the Framingham study, we see those single measures of cholesterol are actually poor predictors of risk. In other words, there's people who have low cholesterol who have heart attacks and strokes, and people with high cholesterol who don't. So we're seeing a little bit of a disconnect between the cholesterol taken in adult age and risk. And likewise, we know that statins, the mainstay of therapy for high cholesterol, actually work in a variety of patient populations. And I have a slide here looking at the Cholesterol Treatment Trialist Collaboration meta-analysis, the most recent one. And we see here that statins work about similarly in secondary and primary prevention, in those primary prevention patients that are high risk and those that are low risk, and also people who have high LDL cholesterol and those who have low LDL cholesterol. So statins seem to give a relative risk reduction for heart attacks and strokes in just about everybody, including those with lower cholesterol levels, as we saw, for example, in the Jupiter study. So this is challenging our understanding of resource allocation in primary prevention, and our view towards statins is changing a little bit. And I'm looking at our slide here now, and traditionally we would say, let's give statins to people who have high cholesterol. Let's find the people with high cholesterol and treat them. But now, as we are emerging in our thinking about allocating statins, we now think of statins more as risk-reducing medications that reduce risk in a variety of patient populations beyond those just with high cholesterol. So if statins are risk-reducing medications, it's challenging our notion also of how we identify risk. In the past, we would have used the Framingham risk factors, particularly someone's age and their cholesterol level, to figure out if they should get a statin. But nowadays, we're thinking about what is someone's actually risk of the disease, risk of atherosclerosis, and asking, do we need to give a statin, a risk-reducing medication, to patients based on their overall risk and their biologic age and likelihood of a heart attack?
So whether and when to give statins in primary prevention is one of the hottest topics in cardiology. Can you give a particular case that illustrates this debate?
Well, yeah, I think a great case is the one that Dr. Roger Blumenthal and I debated in JAMA last year, because 2012 is a tremendous year of debate about statin use. You saw viewpoints that were across the board. Well, we were asked by the editors of JAMA to comment on a case. And the case was a 55-year-old man with a total cholesterol of 250 who had normal blood pressure and was not a smoker and didn't have a strong family history. In other words, a 55-year-old man, asymptomatic, high cholesterol, pretty much isolated high cholesterol. And we were asked to comment on what to do with that patient. And I can tell you, there's just dramatic divergence in opinion on this. So we were debating Dr. Rita Redberg on this case. Well, Dr. Rita Redberg believes that most patients who are asymptomatic in primary prevention don't need a statin. Her viewpoint there is that since statins haven't definitively been shown to reduce total mortality in a short trial period of 3 to 5 year follow-up, that no one really should get statins in primary prevention. An opposing viewpoint is that voiced by many people, including such luminaries like Paul Ridker, who take a trial viewpoint and say that, well, if patients would fit into clinical trial criteria where statins work, we should treat them. In this case, they would say we should treat just about everyone like this who has high cholesterol and presumably high LDL cholesterol with a statin. We argued actually a middle ground. We said further testing in this patient might be appropriate. And we used data from MESA to estimate what the likelihood of this person having coronary calcium using, like I said, data from the MESA study. And I've got the slide for this here. You can see that someone who fit this criteria of having isolated high cholesterol would have about a 50% likelihood of having no coronary calcium, about 37% likely of having a mildly elevated calcium, and a 13% risk of having very high calcium. Then we looked at the event rates and then calculated what the number needed to treat would be if you would give these people a statin, a person who fit this criteria. And we see that statins are very unfavorable if someone who had isolated high cholesterol has no coronary calcium, which is about 50% of the time. And statins are very favorable if someone's got elevated coronary calcium. So we started to make a risk that maybe we shouldn't be treating, or make an argument that we shouldn't be focusing on cholesterol as much as actually someone's risk of atherosclerosis or their atherosclerosis burden itself.
But are we really at the point where we can recommend withholding therapy in certain groups of people who may fit the traditional guidelines, but based on what you have just told me, are unlikely to derive benefit?
Yeah, this is a controversial issue and a very interesting one. But there is no doubt that there's a fair amount of people who fit our clinical trial criteria who, if you measure it, don't have a lot of coronary calcium and their risk is low. And likewise, there's some people who don't fit the trial criteria who have elevated coronary calcium and we think are at risk. So we think that there may be a scenario where you can take someone, for example, with isolated high cholesterol, like the patient in that case. If you measure the coronary calcium at 0 and that patient doesn't really want to take a statin, that you can then double down on lifestyle interventions like exercise and diet and really focus on those things and defer pharmacotherapy in select cases where there's a calcium score of 0. So this leads me to an interesting question, which I think is interesting for our community here, Nathan, to debate, which is who benefits from a statin more? Is it someone with isolated high cholesterol, for example, an LDL cholesterol 160 or 190, but no other risk factors? Or does someone benefit from a statin more who has a normal LDL cholesterol, let's say of 100, but has an elevated calcium score and maybe another risk factor? This is a debate there's no answer yet, but it gets to this question that we've asked. Are we focusing our treatment on cholesterol only, or are we focusing our treatment on risk of atherosclerosis?
So finally, if we're treating risk instead of cholesterol numbers, should we be less concerned about multi-drug regimens for reaching certain LDL goals?
So once again, another hot area of debate, LDL goals. Do we need LDL targets? Of course, there are some people out there that argue that it doesn't make a lot of sense to have LDL targets because none of the clinical trials were arranged in ways trying to get patients to a particular goal. They usually randomize patients to placebo or a statin. But there's a lot of biologic and pathophysiologic data that suggests that there are optimum levels of cholesterol. So this is difficult. But what we have seen is that these other add-on therapies to statins, for example, niacin and fibrates and omega-3s recently, have been disappointing in clinical trials as add-on therapy, which is raising the question, when is the appropriate time to use those drugs to try to further lower the cholesterol? Who do we try to push the cholesterol really low on? And this is a difficult question, but what I would say in our case that we've discussed today, this person with isolated high cholesterol, let's say they took a statin and they didn't reach the current goals from the ATP3 guidelines, or let's say they couldn't tolerate a statin. I would be hesitant at this time to push multiple drugs to try to reach a target in my head of an ideal cholesterol when I'm not even sure how at risk this patient is. And I think we need to reconsider who we are focusing our most aggressive therapy on. And I like to think that focusing our most aggressive therapy on patients who have documented atherosclerosis, for example, with a calcium score in these middle intermediate cases is very helpful. But once again, this is a hot area of debate, and it gets at this question of what the new guidelines are going to even say.
So do you feel the world is moving more toward treating atherosclerosis risk compared to treating cholesterol?
Well, that's an interesting question. It'll be interesting to see what the new guidelines, which we expect in the fall, will say. I expect that they'll still stay on a risk-based paradigm where we calculate someone's global risk and allocate treatment accordingly. And I think it'll, even more than prior guidelines, focused on statins. And I think there may be a de-emphasis on cholesterol thresholds and cholesterol goals, where we say, for example, we don't treat this patient because their cholesterol is already acceptable, or we try to push multiple drugs to reach a particular goal. I think the guidelines may be more like calculate someone's risk. A calcium score would be an option, or with a global risk score, and treat with the dose of a statin that's potent enough to lower the cholesterol by a certain percent, but not focus as much on particular numbers of the cholesterol.
Well, thank you so much, Dr. Blaha, for your insights today, and I'd like to thank all of you for your attention today, and hope you'll visit this cardiometabolic community frequently. Again, this is Nathan Wong for the CardioSource Clinical Community on Cardiometabolic Diseases.